Neely. I'm a consultant in clinical biochemistry and metabolic medicine at the Royal Victoria Infirmary in Newcastle and run the lipid clinic there.
We asked Dr Neely to tell us about familial hypercholesterolaemia in the UK.
At the moment, we have guidelines developed by NICE which help us to identify patients who are important to follow up in terms of early treatment and also identification of other family members who may be similarly affected. And principally we're talking here about familial hypercholesterolemia or FH. But there are other inherited lipid disorders which are similarly associated with early cardiovascular disease, and where there's also a need to identify family members at an early stage. The first opportunity may arise when patients come in for treatment of an acute coronary syndrome, for instance, and we're particularly keen that cardiologists are aware of these conditions, and that if they suspect that someone may have an inherited lipid disorder, that they're promptly referred to a specialist, not necessarily for advice on treatment, but for advice on family follow-up. Because it's the family follow-up which would enable us to find other family members before they present with an acute coronary syndrome themselves. And that's the gap, I think, that there has been for many years in what we're doing with lipid disorders in the UK. There has been a lot of progress in the last few years, and particularly within the last 18 months. There's been a quality standard has been developed based on the original FH guideline for familial hypercholesterolemia called CG71, and this new quality standard was called QS41, and it summarised the key points and particularly the need for early identification, for genetic testing where it was thought that someone had a clinical diagnosis of familial hypercholesterolemia, for testing of children, ideally before 10 years of age, and for initiation of high-intensity statin therapy in adults, and early treatment of children as well. So I think that quality standard has focused the minds, and I know that following the publication of that quality standard, a lot of the newly formed CCGs decided that they wanted to be able to point to what they had been doing to fulfill those quality standards for FH. And at the same time, we were delighted to have the support from British Heart Foundation to fund some specialist nurses, as long as the future funding was guaranteed. Heart Foundation would pump prime this against the background of provision of genetic testing both for the patients and their families. So this has actually resulted in within England for the first time some programs for implementation of genetic testing along the lines of what's been previously seen in the devolved countries, Scotland, Wales and Northern Ireland. So we're now starting to see for the first time the systematic identification of previously unidentified family members.
How many people are affected with FH in the UK?
We believe there's probably about 100,000 FH patients out there that haven't previously identified, and that's based on 1 in 500 of the population being affected, somewhat around 60 million. 120,000 therefore cases, of which we believe only about 20,000 have already been identified, so leave possibly 100,000. And in fact, recently it's been questioned as to how accurate the 1 in 500 figure really is, and there have been a number of studies been undertaken to test big populations of patients with LDLs greater than 5 and those with early coronary disease, and they are kind of pointing to something closer to maybe to 1 in 200 to 1 in 300, and rather than the 1 in 500 we've always relied upon. So it's possible that the treatment or the identification gap may be greater than when we previously realised.
FH rates are very high in the Netherlands, and Dr Neely told us about the Dutch experience and development of their scoring system.
The challenge has been to, within the patients that we've always talked about with the cholesterol greater than 7.5 or the LDL greater than 5, to take from those the ones that are most likely to have a monogenic cause of hypercholesterolaemia, which then will track through the family as an autosomal dominant, that is 50% of first degree, 25% of second degree relatives affected. And if you simply take the LDL of 5 plus a family history, that just is not specific enough, and some efforts have been made to refine this. In Europe, the Dutch Lipid Clinic Network score has been used as a sort of way of deciding who should have genetic testing. A score of greater than 6 normally goes with an LDL of greater than 6.5 plus elements of family history, which is a slightly higher bar, and possibly identifies a group of patients who are more likely to have a genetic mutation. And this has been used in Wales in a modified form. They've called it the Welsh score, not surprising, I think. And the use of that there has allowed them to perhaps be more economical in the use of the genetic testing and avoiding testing families where they're very unlikely to find a mutation. However, it does still have the limitation that for each, if you like, LDL cutoff, there is no difference between a 25-year-old and a 65-year-old, or between males and females. So it still perhaps is not a sharp enough tool, and there's a possibility that we might be able to refine that by feeding back information from the projects that are established so far, and coming up with a better scoring system. With more recent assays for lipoprotein A, we're now actually able to find lipoprotein A at a very high level in some of the families who have got maybe more moderate to severe elevations of cholesterol, but a very strong family history, and that they may be mutation negative for the FH genes, but the very high lipoprotein A itself is a strongly inherited trait, and we may then be able to use the lipoprotein A measurement within families to identify the people who are at greatest risk. It's a lot cheaper, in fact, than doing genetic testing to measure lipoprotein A.
What can be done in both primary and secondary care to improve the identification of patients with FH?
I think that the primary care are actually trying very hard, and many of the CCGs have become acutely aware of the quality standards, and they're actively seeking help from lipid specialists to educate their GPs to pick this up. I think one of the biggest gaps is perhaps at the sharp end of the secondary care, where people are coming into hospital and enter a process that doesn't actually require anybody to check what their cholesterol result was, because in fact everybody is getting put on high intensity statin therapy as soon as they've had their ST segment elevation recorded, and perhaps people are not asking the question, could this be FH? Why is this patient only 50 years of age coming in with a heart attack? Maybe the question needs to be asked at that point.
Where do Heart UK and the British Heart Foundation fit in?
Well, Heart UK is a patient and professional organisation, and they have taken the part, if you like, of the patients, I suppose, particularly here in trying to promote the implementation of the guidelines. Heart UK has been a stakeholder in the guidelines, both the lipid modification guidelines and the FH guidelines, and Heart UK is very anxious to see them fully implemented throughout the UK. So Heart UK worked with the Heart Foundation to develop the FH Nurses Programme. The Heart Foundation provided the financial muscle to make this happen, and Heart UK provided a lot of advice and got patient stakeholders on board. Heart UK also has a group which, in fact, these days I co-chair with a GP called David Milne from Essex, and that group meets regularly on a teleconference to discuss progress with the strategies for getting implementation around the country to a higher level than is currently happening. And that, very importantly now, that's all about influencing the CCGs to see this as a high priority for them. And some CCGs have taken this up. The northeast in Newcastle has been one, and around Southampton in the south has been another, where they've seen this as being something they can do something about, and they'd also see that, relatively speaking, it's not a massive amount of money, but it can have a huge impact, and can be very, if you like, visible as a demonstration of their commitment to quality of care. One of the recent successes was to get one of the CCGs led by Peter Green in Medway to undertake an IT-based project using BMJ software for doing audits of computer databases, and they used that to actually find FH patients, and they supported that with deploying a nurse to go and actually see the people who had been identified, and to then use the Simon Broom criteria and the Dutch score to try to corroborate the diagnosis and to confirm that, to allow them then to be used as an index case for a family cascade screening. And that was fantastic, because I think a lot of the GPs were seeing this as a potentially huge number of unidentified patients, and with the aid of the audit software, it's possible to actually flag them all up on their computer systems and make this, and turn this into a manageable workload that they could actually start and work their way through.
Will the NHS be able to afford these new therapies?
I think there needs to be some further thought given the precise role of new therapies and how they can be used to the maximum effect alongside existing therapies like the statins. Certainly, I think if the cascade testing identifies patients at the age of 18 years rather than 48 or 58 years before they've got any coronary disease symptoms, then the 50% reduction that you can achieve in most cases with statins and ezetimibe is probably going to be enough to stop those people ending up, if you like, in front of a cardiologist in future. Particularly if that's backed up with risk factor interventions, telling them how important it is for them, they don't smoke, that they have a healthy lifestyle, diet and exercise. All those things dialed in at a young age, ideally, so that by the time they're 18, they're fully sorted out. That would be a huge boon to the prevention element of an NFH. And clearly we're avoiding a lot of healthcare costs on those people. So that hopefully will actually start to pay back in the coming years. The people that are getting to cardiology, that are being found to have coronary disease and who we can treat with statins effectively, but perhaps aren't achieving targets, well, it's possible that new therapies may have a role with them to get them as low as possible. And what we'd really like to see is the new therapies being deployed in such a way as you get regression of unstable lesions throughout their vasculature.
Will the new drugs need to be taken lifelong?
Whether you need to have them on these new therapies for life, or whether they can be given an intensive period of treatment for maybe 3 or 5 years. We've certainly seen that imaging studies show very rapid disappearance of cholesterol from the arteries of patients with coronary disease, and it's possible that if you're able to stabilise their disease and deplete the arteries of cholesterol, that you may then be able to have them in a stable condition, just managed on statins 5 years down the line, and you may not necessarily have to follow the simple, if you like, paradigm of the new high expensive therapy gets started and is then maintained for life. It may be that it could be a short, sharp, intensive period of treatment to stabilise everything for that patient. So there's more than one way that you could see these treatments being used. Certainly for the highest risk patients who, for instance, are identified late with familial hypercholesterolemia and have extremely severe disease, people who perhaps aren't homozygotes but are the next best thing, well, they may need indeed everything you can throw at them, including the newer agents, maintained lifelong, but perhaps they'll be a minority, and that you might not necessarily have to have everybody who receives these high expensive, high cost new treatments given lifelong, as we've always been used to.